Our 11th webinar, and this time the topic is on shoulder, and Dr. Gautam Tavari from Mumbai is going to talk about biomechanics of the shoulder with respect to shoulder arthroplasty. Dr. Gautam Tavari is a consultant orthopedic surgeon in Mumbai. He operates at different hospitals. He has been in the UK for the last 15 years. He was trained in Sheffield and he was a consultant at South Yorkshire. Over to you, Dr. Gautam. You can share your screen.
Yes, I'll just share my screen. Welcome, everybody. I am going to talk about shoulder biomechanics, especially in terms of what it should be for FRCS orth, i.e. what is expected of you when you go for an FRCS orth exam. Also, its relevance in terms of shoulder replacements and when you should use these principles and apply them for shoulder replacement surgery. Now, a little bit about myself. I have been in the UK for a long time, and as always, am FRCS trained, but also a specialist sports surgeon. I trained in the UK, did my fellowship there, was a consultant, also was a faculty at the Miller course and the Chesterfield FRCS course. Also, obviously, faculty in the BOA FRCS course. My scope of practice is largely joint preservation and arthroscopy with upper limb replacement surgery, and I work at Hinduja and Nanavati Hospital. With Apollo and Vocard, I also have my own clinic here. So shoulder biomechanics, with regards to FRCS orth, where do you get the questions related to these biomechanics or replacements? So you will get them in written, which is MCQ and EMQs, because they are recall questions and you need to know your biomechanics to answer those questions. You'll get them in vivas as related questions, especially on the tables of adult pathology and trauma. And obviously you'll get questions related to them in clinical long case. So I think I missed the L there, but clinical long case. So let's go a little bit about anatomy, because that's what they're going to ask you or expect you to know. I am only going to talk about relevant anatomy and nothing more than that. So relevant anatomy about the humerus is essentially you need to know about the neck shaft angle of the humerus, which is between 130 and 140. You need to know that the humeral head is retroverted by about 30 to 40 degrees. And you need to know the muscles around the humerus. You also need to know about glenoid. Glenoid, you need to know that there is a tilt to the glenoid, which is about 3 degrees, superior tilt. There is a retroversion of about 7 degrees in the scapular plane, but in the coronal plane, it has about an antiversion of about 30 degrees. Also, glenoid is smaller and is a part of the scapula, which allows the combined movement. And you need to know about the clavicle, because acromion, again, a part of the scapula, attaches to the clavicle. The clavicle rotates or circumducts when the shoulder abducts beyond 90 degrees. So you need to know that the clavicle plays an important role. So does the coracoclavicular ligaments as they hold on to the scapula whilst the clavicle rotates. The muscles, on the muscles, you need to know muscles in terms of glenohumeral, which is all of your rotator cuff muscles, your deltoid, your biceps, and the pec minor. You also need to know about the scapulothoracic muscles, which are your trapezius. A part of it is also deltoid, but largely your rhomboids and your serratus anterior. The thoracohumeral muscles, which essentially work around the thorax and the humerus, and they are your latissimus dorsi and your pec major. So one anterior, one posterior. Movement of the shoulder, again, that is an important question, and they will try and ease that out of you to find out, do you know what is scapulothoracic movement, what is glenohumeral movement? Glenohumeral movements, they are largely isolated at 30 degrees of abduction and 60 degrees of forward elevation. These are pure movements and they happen at that time. After which you get the scapulothoracic movement that plays a role in getting your arm forward. They would also want to know about scapular rotations, and the scapular rotations are largely important to stabilize the glenohumeral joint and movement of the whole shoulder girdle. The ratio of the movement is 2:1. Up until I think 120 degrees of forward elevation, and abduction, but over and above that, you can pretty much say there is a 1:1 ratio of movement. Coming on to glenohumeral stability, this is quite important because this can be a part of your EMQs and MCQs. You need to know your ligaments around your glenohumeral joint. You need to know the bony anatomy and the ligamentous or the labral anatomy. So bones wise, you have the glenoid. Glenoid is about 1/3 of the size of the humeral head. It is covered on a very different manner in terms of the cartilage. When I say that, the peripheral cartilages are thicker than the central cartilage to allow an element of concavity. The humeral head is again important because a large portion of it is cartilaginous, and the stability of the humeral head depends upon the presence of labrum and the other tissues around the humeral surface, which is the superior, middle, and the inferior glenohumeral ligaments. So the importance of inferior glenohumeral ligament, this is the most stabilizing structure, especially when the arm is abducted beyond 90 degrees and upwards. It forms a hammock. It is, it's got an anterior and a posterior band, and it arises from largely from the labrum, but also a little bit from the glenoid itself. The middle glenohumeral ligament arises from the supraglenoid notch going all the way up to the lesser tuberosity. It forms an important structure for anterior translation and external rotation, especially when the humerus is between 45 and 60 degrees. So this, you've got to remember the degrees of each because you need to know which ligament is active at what degree, and that is an EMQ or an MCQ question for you. The superior glenohumeral ligament forms your rotator interval and essentially also forms the undersurface of your subscap and the biceps pulley. And followed by this, you have the dynamic stabilizers of the shoulder. Now, the dynamic stabilizers of the shoulders are your muscles, essentially, and the long biceps, along with your coracoclavicular ligament, coracoacromial ligament, and coracohumeral ligaments. So they play an important role. So in terms of FRCS, what are you going to get asked? So you will be given an X-ray and you will be asked to describe. The commonest question is describe the X-ray. Or once you've started the description, then it will be talk about positive clinical findings, or how will you manage the patient. Now this becomes a part of your viva, and it's generally seen in the adult pathology or maybe in trauma if the cases of trauma, which would eventually take you to shoulder replacement surgery. In terms of describing the X-ray, you are expected to say that the humeral head is migrating superiorly is in touch with the acromion. You can talk about acromization of the humeral head. You can say that there is a glenohumeral OA, and you can say that this appears to be a rotator cuff related arthropathy. Now, there are secondary changes, but you are expected to just describe the X-ray in quick time, focusing on the facts that you see on the X-ray rather than diverging on that the rest of the X-ray looks normal and wasting time. This is important because you've only got certain amount of time for a case and you are expected to answer all their questions in that amount of time to proceed forwards. In terms of clinical findings, now a patient like this is expected to come with a stiff shoulder or a painful shoulder with restricted range of movements. And then you can talk about your assessment of rotator cuff and what you expect of the rotator cuff, especially talk about signs like extensor lag sign or restricted movement with pain and the strength of your rotator cuff. How will you manage this is a detailed question, and they'll generally want to tease step by step out of how will you manage things in patients like this. So going across to shoulder replacements, they're going to probably expect you to say you would manage this with a shoulder replacement. And the question then diverges into what do you know about shoulder replacements? And you're expected then to talk about the various kinds of shoulder replacements that you can do. So you can do a hemiarthroplasty, you can do anatomical shoulder replacements, or you can do a reverse shoulder replacement. So this is what is expected of you in terms of shoulder replacements. They would probably want to understand the principles of these surgeries rather than knowing whether you've done how many or whether you know how to do it. So in terms of principles, you need to talk in a language that is a lot more generic but relatable. And you need to be able to describe various parts eloquently of a shoulder replacement. Now, in terms of shoulder replacement, they'll expect you to know components and their designs. When they talk about components and their designs, you really need to be talking about individual components. So when it comes to humeral component, what kinds of components are available for you? So they can be a stemmed component, it can be a stemless component, it can be a surface replacement. If it's a stem component, whether it's what kind of stemmed component it is, what kind of offsets you get in those stem components, what kind of stems you get in that stem component. With terms of glenoid in an anatomical replacement, you need to know that there are flat back glenoids and there are spherical back glenoids, and what is the current trend in terms of choosing the glenoids. Now you can see in the pictures, you can see metal back with polyglenoids. They have come across as a bad choice of component, and the results are showing that they are not so good anymore. So you can go in, they can show you or give you a component like this, and they can ask you to talk about it. Now you can choose either to diverge into basic sciences with this if you're good at it, or you can diverge into the clinical aspects of things. The safer option is generally diverge into the clinical options, clinical side problems associated with this. However, you do need to understand the wear patterns in a metal black glenoid, and the commonest cause of wear is a third party wear or a third particle wear, whichever you choose to answer. The commonest glenoid nowadays used for anatomical shoulder replacement is all poly spherical back glenoid, and the reason for this is it helps in reducing the rocking horse phenomena on the glenoid component, as a result of which there is a lot less wear on the glenoid component. So what are the principles of replacements that is expected of you? So the first thing they expect you to say is that you would replicate the anatomical size of the humerus. It is proven time and again that reconstructing a joint essentially means replicating the anatomy uh, of the various parts of the joint. So, be it glenoid or be it humeral head, you need to understand the size of the uh, parts or the sections of the joint involved and then replicate it accordingly. You need to talk about restoration of normal center of rotation. Now, this is important because changing the center of rotation effectively causes increase in wear and brings in a lot of variables in the uh, treatment of the patient. So the variables can then be that how would you, if you change the center of rotation, it then changes your offset and how do you manage that? And then you're digging deep into the intricacies of shoulder joint replacement, which I do not think you want to go in. So you try and stay as clear of complex questions. In terms of humeral components, you expected to talk about offsets. So humeral components, you can talk about the mediolateral offset and the anterior posterior offset. You can talk about the neck shaft angle of the component and how that helps you plan your surgery. You can talk about the angle of stem insertion because that is quite important in terms of managing the neck shaft angle of the humerus. The uh, next you can probably diverge on is the types of stem, and you have the thin cemented stem prosthesis and the advantages of the thin cemented stem prosthesis because it allows you to manage your neck shaft angle in case your cuts are not right or in case your angle of insertion is not good. Uh, However, it has the disadvantage of increasing another wear pattern because you are increasing an interface. So you're introducing cement. So you have a bone cement interface and a cement prosthesis interface. Uh, you can then diverge into talking about press fit uncemented stems. Now these are what we normally use, but requires a significant amount of accuracy because you have to recreate the anatomy and you do not have choices of adjustment as they have a very press fit, and once they have fit, they cannot be changed. So you can then talk about the need for using modular systems rather than using non-modular systems in a press fit situation. But these are the two kind of stems that are commonly used. In a trauma scenario, you are more likely to err on the side of caution, and you would prefer talking about thin stem, cemented prosthesis, because it allows you to allows you to arrange heights and allows you to arrange the angles on the uh, replacement. With regards to surface replacement, arthroplasty, uh, obviously you must be aware of Copeland resurfacing. It was designed in the UK, and from the designing centers, it had really good results and was used significantly across the country before going on to stemless prosthesis or even stemmed prosthesis. But you need to know the results of Copeland and was it reproducible in other people's hand or not. So all these questions will diverge you into giving confidence to the examiner that you understand your subject and you are going to be safe with intervention. You need to know advantages and disadvantages of pretty much most things you talk about. Because if you do mention something and you do not know the disadvantages or do not know the limitations, then it does not come across that you understand what is expected of you. Coming on to reverse polarity total shoulder replacement, they are quite often used now. What I'm showing you again is a principle of it, which essentially tells you a component design, which means you have a glenoid base plate and you can talk about the mechanism to fix the glenoid base plate. It can be a central screw or a central peg with peripheral screws. Again, it can be spherical or a flat, followed by attachment of the glenosphere on it. You can talk about the humeral component, which is again modular or fixed. You can talk about platform systems, which allow you to change from a reverse to an anatomical, an anatomical to a reverse system fairly swiftly in case of the surgery. And obviously, you need to talk about the humeral tray and the tray, the angles of the tray that can be available with the modularity to allow offsets and lateralization of the glenoid component. Now, I would not divulge into lateralization because it's a concept that you need to understand thoroughly unless and until you are a shoulder surgeon. You don't want to get into intricacies of shoulder surgery. You just want to stay clear and say that it is made of modular components, which is a stem, a neck, a humeral tray, a glenoid base plate, and a glenosphere. So effectively 5 components. And then you can steer clear yourself of the component business in terms of reverse. In terms of principles of levers, you have to understand that the most important principle is medialization of the center of rotation. And in doing so, you increase the mechanical advantage of deltoid muscle. So it shifts the center of rotation inferiorly and medially, and this is what they're looking for. If you say this, they would probably know, they'll probably understand you understand the principles. Then you get along talking about deltoid. So it has a longer fulcrum, a longer lever arm. The prosthesis itself can be called as a fixed fulcrum prosthesis, and the elongation of fulcrum gives you the mechanical advantage to substitute for a deficient cuff. So once they understand that your basic principles of doing reverse shoulder or advising a reverse shoulder are clear, they would then want to steer you into a little bit deeper and ask you about when you would do it, what are the indications for or contraindications for the shoulder replacement. Once you get into indications, you need to be very clear that you talk in a very sequential manner and you talk about simple things first, like osteoarthritis. This is the most commonest. Inflammatory arthritis or rheumatoid arthritis, these are the second choices for indications. And the complex bit is fracture. Now, fracture surgeries are generally done by the shoulder surgeons, and you're well within your rights to say this is not something that you do normally, and you're more than happy to send it across to somebody who does this regularly, and that is an acceptable answer. You can then go into talking about other indications, which could be a malunion or a non-union of proximal humeral fracture, or indeed for a reverse total shoulder arthroplasty, it's a cuff arthropathy, which is the next commonest cause or indication for considering a reverse total shoulder replacement. Coming on to contraindications, so you need to know when you should not be advising shoulder replacements, and these are non-functioning of the muscles. So what non-functioning are we looking at? So in an anatomical shoulder, obviously you're looking at non-functioning of the rotator cuff, whereas in a reverse, you're looking at non-functioning of a deltoid. However, if you have non-functioning of both of these, then you do not need to suggest a shoulder replacement. There are other modalities of treatment, and you need to be talking about those modalities of treatment. In case of nerve injuries, essentially axillary nerve injury, and if you're getting into nerve injury, then you need to understand how you're going to how you're going to treat a patient with nerve injury. So you need to know about your muscle transfers, and you need to know about your nerve transfers, or at least have some idea of how you're going to sort the patient. If the patient has any active infection, or indeed they have any intractable instability. So arthroplasty is not advisable if patients have intractable instability, because it is essentially quantifies and magnifies the instability and makes the operation unsuccessful. So you have to look for intractable instability and be very careful of suggesting shoulder replacements in patients who have uh, intractable uh, instability. So you would go the extra mile to explain everything on intractable instability. Obviously, you can't suggest a replacement if you know that the patient's not compliant. It's a soft indication because patients can become compliant again. But it is an indication where you would not consider a shoulder replacement. Last but not the least is Charcot arthropathy. It is a clear contraindication for suggesting shoulder replacement in a Charcot arthropathy. And if you do diverge into details of it, you have to understand that it's a neural problem. It causes diffuse resorption of the bone, and it is a painless process. So the patients won't come to you with pain. Essentially, they come to you with restricted range of movement. If you successfully answer all this, they would then talk to you about operative planning for a reverse shoulder replacement. These are basic principles of operative planning, and you can use the same principles that you use for a hip or a knee replacement operative planning, and it can be talked about in the shoulder replacement operative planning. However, there are a few specifics that you need to answer and need to pay attention to. So you need to be talking about cuff health, and in that sense, you need to be talking about, is the cuff intact? Is it deficient? If the cuff is intact, then what is the state of the cuff? And how do you identify the state of the cuff or the cuff health? You need an MRI scan to identify the state of the cuff. You need to understand Goutilier's classification for talking about the rotator cuff muscles and its health. If the cuff is deficient, then you need to know, is the deficiency repairable, or is the deficiency not repairable? So you need to be knowing about the cuff defects, and in what cuff defects you would be suggesting a shoulder replacement surgery. So your cutouts on cuff defects is what they are looking for. You need to be talking about bone stock. The bone stock both on the humeral side and on the glenoid side, because both of it is important in terms of planning your surgery. Essentially, if there is a particular component that you intend to use, what kind of bone stock is required for that component. So if you use a very standard stemmed prosthesis on the humerus side and a poly prosthesis on the glenoid side, then you just need to be worried about the glenoid bone stock, because you can pretty much rebuild the humeral bone stock. You need to know about wear patterns of the shoulder joint. Essentially, the wear patterns on the shoulder joint changes, and here they would probably want to know if you know the anatomy or if you know the normal values of retroversions and tilts on the glenoid, because the wear patterns completely reverse the anatomy, and for arthroplasty you need to recreate those anatomy again. And you need to be talking about contractures, or you need to be looking out for them because they will have a significant effect on what you do and how you do it. If you are successful in glenoid in wear patterns, the typical question is, do you know about any wear patterns? And they're expecting you to know about glenoid wear patterns. There is a Walsh classification for the glenoid wear pattern, and he divided it into A, B, and C. You need to know that A is a central wear, A1 is minor, A2 is major, B is subluxation with posterior wear, and C is a retroverted glenoid. So essentially, the most difficult shoulders to reconstruct are shoulders which have a B2 or in fact a B3, which is a subdivision of the B wear based on the degree of posterior glenoid loss and the translation or subluxation of the humeral head. So they are the most difficult ones to reconstruct. They often ask you about the pros and cons of the total shoulder replacement, and you need to have at least some idea of pros and cons about total shoulder replacement, because the question would be, why are you going to suggest that, or why do you think total shoulder is going to work in this patient? And the pros are, for a total shoulder, is it recreates anatomy, which means it gives you a congruent shoulder joint with a reproducible offset on the head and a congruent glenoid. It restores the version of the anatomical shoulder and allows significant advantages in terms of movement. Now, the movements are much better in total shoulder replacements, and you can be asked about any evidence that you know about this. And there is enough evidence in the literature to suggest that a total shoulder replacement has a lot better range of movement compared to hemiarthroplasty. It provides a significantly better pain relief. What are the disadvantages of doing a total shoulder replacement? It's an increased exposure. You are taking across tissues to enter into the glenoid, and you are creating angles and reaming normal bone to allow your components to fix. So they always have a risk of problems in terms of the exposure. There's always risks of loosening and a failure of your components. Now, in an anatomical shoulder replacement, the commonest reason for failure is loss of rotator cuff, and that pretty much results in failure of the construct because your force couples don't work properly. Again, you will get increased amount of loosening if you use metal back glenoids, or for that matter, if you have not corrected your if your cementing is not good across the glenoid. it is a technically difficult procedure, hence the risk of technical inadequacy increases, which further causes problems in terms of longevity of the prosthesis. And obviously revision is going to be difficult because it would result into a significant amount of wear or osteolysis of the original construct. So you will then boil down, you will go back on talking about bone stocks and prosthesis to counter your problems with this. They will ask you about complications. So you can talk about common complications, which is periprosthetic fractures. They are the most commonest. This can happen on the humeral side and happen on the glenoid side. On the humeral side, you need to know that the bailout is using a stemmed prosthesis or using a cemented prosthesis. If you do incur a periprosthetic fracture and then doing treatment of the patient in terms of the periprosthetic fracture, so taking things slowly for the patient, restricting the range of movement. You also need to determine your strength in terms of the construct that you've used to then be able to deal with the periprosthetic fracture in terms of using wires or indeed using plates if you have to, or bone grafts. On the glenoid side, it is very tricky and it is often not uncommon to bail out by just doing a hemiarthroplasty if you have a glenoid fracture, so that the load on the component is taken away. We talked about instability a little bit, but they'd expect you to know more about instability. The instability often results in an anatomical shoulder from lack of rotator cuff or indeed rupture of the rotator cuff, the tightness of the subscap or tear of the subscap, and that would further increase risks of instability. Your handling of the coracoacromial ligaments and the coracohumeral ligaments, because they play a little bit, they'll play a small role in terms of anterior or anterosuperior stability of the humerus, and obviously infection. That is another risk factor or complication that you deal with, and then you diverge into infection. So in summary, you kind of are required to know basics of arthroplasty. You're not required to know the details of arthroplasty. If you're doing well, they might take you into talking about approaches for arthroplasty, and you can then go into a deltoid split approach or a deltopectoral approach and talk about those things as far as your viva is concerned. But it can pretty much be asked in any scenario in the exam, especially in a long clinical case and in the viva sections, because the viva sections are so broad that they can take you anywhere they like to know whether you understand the principles and you understand why you would be doing a certain procedure rather than being able to do a certain procedure. Another small complication is an inadequate version, but that is a section into revision surgery. So I don't expect you to take you into revision surgery, but this is something that you need to understand to be able to say. So it is just something that you'd say that there is a risk of inadequate version, and that can be a cause of complication. So happy to take any questions if there are.
Okay, thank you, Gautam, for that excellent lecture. I think you've covered almost everything on shoulder arthroplasty for the FRCS. We don't have a question on the chat box, but someone has messaged me about reverse shoulder arthroplasty. So isn't it a very hot topic, reverse shoulder arthroplasty for the FRCS?
So reverse shoulder arthroplasty is a hot topic, or in fact, shoulder arthroplasty itself is a hot topic. Because a lot of anatomical shoulders get converted into reverse because they can take you pretty much anywhere. So they will take you into saying, okay, what are the reasons of failure of an anatomical shoulder before they get into reverse? And as soon as you say about the most commonest is a rotator cuff tear, they can take you into rotator cuff. And they have touched the arthroplasty, but actually they are going into rotator cuff and they're asking you questions about rotator cuff now. So they can pretty much take you anywhere they like. In terms of reverse shoulder arthroplasty, unless and until you say that you are interested in doing shoulder surgery, you can pretty much talk about the basic principles, because they don't expect you to know reverse shoulder. They don't expect you to know how to do a reverse shoulder. However, they expect you to have seen one and talk about approaches, because that is the same approach you're going to use for your fractures or your access to the glenoid if you have to. If you don't have a surgeon around who can help you with shoulder, if you are interested in shoulder, by all means, take them into the depth of your reverse shoulder arthroplasty. And you can talk about components, you can talk about how it works. All they want to know is, do you understand the principle of a reverse shoulder arthroplasty, which in a certain sense is medialization of the center of rotation, inferiorization of the center of rotation, increasing the fulcrum, and giving deltoid a advantage in terms of mechanicus of the shoulder. So that is where they go and they stop. They don't take you into details of it. If they do take you into details of it, obviously you're doing really well.
I think it's the candidate who has to steer through the questions, right? He has to take the exam ideally, where he wants, where he knows.
It is very difficult. Having given FRCS, it is very difficult to steer the examiner. The examiner at any point in time can divulge you wherever they want, because the topics are so vast and they are only touching it. They're not going into details of a topic. If they're going into details of a topic, it essentially means that you do understand, and they're just trying to see whether you actually understand or you just recalling what you've learned without understanding. So they will take you a little bit into the depth, get a few questions of you saying, what if we don't medialize? What happens in a reverse shoulder? So you can only answer that question if you understand what medialization means. Yeah.
Okay. The other question that has come up is, what is the role of superior capsular reconstruction? Because there's a lot of talk about superior capsular reconstruction for irreparable cuff tears, right?
Correct. So it is, you can very well get away by saying it's an experimental procedure. It is only in the hands of people who are doing them. It is reproducible. However, the results we do not know. If given a choice, I would do a reverse, because that's a safe way of going. They don't expect you to know advanced arthroscopy.
Okay.
You need to know what superior capsular reconstruction is. This is essentially reconstructing a superior capsule so that you prevent superiorization of the humeral head. Because they can say, why would the head superiorize? And they will take you back into mechanics. You need to then talk about force couplings, and you need to talk about how the supraspinatus and the deltoid work together, and the infraspinatus and the teres minor work as a force coupler to improve concavity compression at a shoulder joint. And then they know you understand this.
Perfect. I think there are no more questions, and thank you for that wonderful lecture, Dr. Gautam. It has been very enlightening for everyone, and we look forward for more of these lectures. Thank you very much.